Welcome to another episode of the Face podcast. I'm here with Dr. Ben Talei. We have shot an episode in the past, but of course we definitely needed to do a part 2. Welcome, Dr. Ben Talei.
Thank you. I'm excited for part 2.
Yeah.
Part 1 was too short.
It was way too short. So you're incredibly generous with your knowledge. I've spent the last few days with many of your colleagues and your name keeps coming up as you being a mentor. And you have an open door policy where you have helped a lot of younger surgeons get to where they are today. So talk to me about why you give back.
Medicine is a field of kind of research and teaching and always has been, even though plastic surgery really isn't all the time. And I've always wanted to be a teacher, so it's inside me, but also I never felt that I had the right to take from somebody else and learn from somebody else, but not give back. It doesn't make any sense to me. Where people would just kind of keep their secrets and not talk about things. Now, for selfish reasons, I teach too, because if I don't teach, then I can't really process things as fast and grow. So it really helps me to go teach every single day, have people in the operating room, discuss things. They watch me, they criticize me, and I have to have a reason for every single move that I make and every single thing that I do, which not a lot of surgeons have. They make moves for no reason. I'm all about efficiency, and I can't do that. And even though teaching kills me sometimes, I travel too much to teach, then I have fear of stopping. It gives me anxiety, because then I feel like I'm not going to be growing as much anymore. Every time I get on stage, you put yourself in a position where people can challenge you, question you. And I like that because I want to have a defense for every single thing that I do, or else I shouldn't be doing it. So for me, it's kind of a continuous growth, and really having people in the OR keeps me entertained too. Otherwise, we're in this private practice in Beverly Hills, and I'm an academic person, I'm an academic thinker, but you get stuck in a private practice world and you don't get to really be yourself. You just become alone, and it becomes this, they have echo chambers now on Instagram, but in the operating room we had that too, where you'd have and this is before the social media echo chambers, you have your own echo chamber in the OR where you teach whatever you want, no one can challenge you, and it ends up propagating down the line to whomever you have taught. They just think, okay, that's correct, this is the way to do it, it's the dogmatic thinking. And we have this in the plastic surgery societies where it's very incestuous, where there's maybe 2 or 3 lineages of surgeons, and they just teach whatever they want, and their evidence is just truth by whatever they cited before.
Sure.
So it's not actual truth. It's like whatever they've said is true. That's it.
It must take enormous courage though to be innovative, because maybe that's why plastic surgeons become stuck, because they're doing the same thing over and over again. But to be truly innovative, you have to try a different way, a different technique. And I assume that that's what you've done along the journey.
Yeah, there's 2 parts to that where the fear would come from. One is experimentation. You would never want to do on somebody to jump untrained to do something, meaning you haven't seen it before, done 1,000 times. And then the other is just the evolution, which is how I go about things, where every day I take a shower in the morning and I think about what I did the day before and where I could have done better, or the 3-month follow-up that I had and where I could have gotten a better result on minutia. On really tiny things, and then you'll come up with an idea to fix it that's not harmful to the patient, that is going to benefit them in many ways, but then at some point you have a little bit of a hiccup. So every time you do evolve, if it's not a perfect evolution, which a lot of them aren't, you end up with a bunch of revisions that you have to do afterwards.
Yes.
For nothing major that you damaged anybody for, but you got 5 improvements on that one patient, but then there's this one downside on some of them where you have to go fix it until you work out the kinks. So that's where most surgeons don't want to jump into. They end up in their comfort zone, and it's difficult for them. They like just coming to work and doing the routine. That's, for them, it's work. For me, it's not work. For me, it's a game. And for me to play my game, I have to keep improving. That's the only reason I kill myself, is because it's a game for me. And for me to win at the game, I just have to keep going and going and going and going. And then if I get to the point where I'm not going anymore and I'm not improving anymore, I get bored with it. And then I just don't want to do it anymore. I want to stay home and sleep. I'd rather do that than come bust my ass from 5 in the morning until whenever, or go to all these conferences and travel. It's way more comforting. But,
absolutely.
And that's what happened to me with lip lifts. So with lip lifts, I created a world of lip lifting, with a new thought process for lip lifting and a new algorithm for lip lifting. But once I got to the point that I couldn't improve anymore, I got bored with it, and I went from doing 10 to 12 a week to now doing 2 or 3 a week, where I'm in the comfort zone for it, just like all these other guys, where I just come in and I do it and it's beautiful, and I like giving the patient that, that talent I have or whatever it is, but it doesn't entertain me as much as like facelifting, for example, facial rejuvenation. There's no end to what you can do.
Just because if my followers haven't listened to the first episode episode, you were working in with pediatric cancer patients.
That was my second fellowship was pediatric birthmarks, which were vascular tumors. So benign tumors, but very large ones that were debilitating.
Do you think that's what led you into the lip lift?
No. The lip lifting came initially from Andrew Jacono, who's the great surgeon in New York who trained me. He was doing lip lifts substantially more than most people were at the time. And in New York, I started doing them, and I did the first few on models that were like beautiful young women that other people would have been afraid to deform.
Sure.
And because I was successful at it repeatedly, and then came back to LA and started doing it more, it gained worldwide popularity for young people. So that's when the lip lift first hit the young market, was when I popularized it in 2014. I didn't know that until it came back to me from a couple surgeons visiting me from Australia and Poland. And they said, no, you're known worldwide for this. I'm like, what are you talking about? I haven't even published it. I just lecture about it. But my lectures went around, and then social media was getting popularity. And that's when the lip lift hit the young population. It used to be a surgery only for 65-year-old white ladies and above. I found a way to do it where you could reproducibly do it on younger people.
So tell me about New York.
Which also, by the way, led to tons of revisions afterwards, because the surgeons get excited when something becomes trendy and popular, and without being good at it, they jump into doing it. So you have, like, right now the facelift craze.
Yes.
And everyone starts getting facelifts by even surgeons who shouldn't be doing it, because they think, oh my God, it's popular, it must be good, the surgeons. And then you end up with, after 2-3 years, tons of revisions. So this is what's going to happen now with this whole facelift craze.
How much of your work is revisions from other plastic surgeons?
Well, there's secondary work, which is just they've had surgery before, and that's tons of them. Actual revision work for facelifting is probably like 20% of my practice, which is a lot. It's substantial, and I don't mind doing those. They're fun. It's just I don't want to do it on a patient who's not nice.
Yeah.
If they're not understanding and nice, knowing that revision work is more complex. It's not difficult for me. It's just more complex, which just means sometimes it doesn't involve a one-stage procedure. Sometimes you got to come back and touch up a little fat grafting or something else, and it's easy to do. You just have to have the patience for it and be patient with me. So I'm very, very careful about whom I do the revision work, especially when they've been damaged substantially before. And it's a hard line for me, because you want to explain to the patient how messed up their face is without scaring them, without really, making them enemies with the last surgeon,
of course,
who may have not done a terrible job, but
just not a great job.
Exactly. You don't want to just, because once you bury that person, you're screwed too. So
100%.
It's a difficult line to walk with revision patients sometimes, but I do a lot of revision work, and I like it. It's fun for me. I like fixing things that other people can't fix.
So I want to go back to New York, because you said that you did train with Dr Andrew Jacono.
Yes.
And you are known for your Auralyft, which is a deep plane facelift. Correct. So is that where you started to learn from him?
Yeah. So he's the one who taught me pretty much all of my rhinoplasty came from Stephen Perlman mainly, and a few other people in New York, and then my facelifting and aging face and cancer reconstruction all came from Andrew Jacono.
Yeah, okay.
Jacono at that time was evolving the entire field, and he pushed everybody in a new way of doing it, which was a combination of prior deep plane techniques, and he had called it the MADE lift at the time. So he was evolving it substantially and really pushing it around worldwide. And thanks to him, it gained popularity, and he single-handedly made facelifting better in the world. He took everyone's bar higher, everybody. And a lot of people hate him for it, but that's what he did. He really improved everybody in the world for facelifting. And I was lucky enough to be there at the time where he had gotten to a point where the finesse was fantastic. And I learned a ton from his facelifting and facial rejuvenation and cancer reconstruction that I used in my birthmarks. Then when I came back to LA, I reproduced that and then started to evolve it myself in a slightly different direction. Where now when people ask me, what is the Auralyft? Is it a deep plane lift? The answer is kind of like a yes and a no. Okay. Where it is not a classic deep plane lift, Sam Hamra, Texas. This is more of an Andrew Jacono type lift, but within it has an entire SMAS optimization, which means I do muscle modulation, and muscle modulation is its own world, and I'm the only one practicing that. So there's nobody else that I know of who's doing it, so I'm kind of on my own with this. But I've been doing it for a while, and it's very successful, and it's, for me, one of the coolest things that I've done, where I can actually change the way people their character appears. So I can make them at rest look happier, more well-rested, obviously, less angry, less sad, less tired, all of that. But also when they smile, I can make their dynamic facial movements better. And this isn't a field that exists. So surgeons aren't analyzing how you used to smile when you were young versus how you smile when you're older. It's not in their kind of purview. What they're looking at is just your neck was down, your neck is up. That's it. I'm kind of past that. I did that. It's great. I can do a great job and I'm still improving it. But for me, the fun now is, can I change the way someone smiles? Where when they smile as you get older, you get like, and
it's tighter.
It's exactly.
Yeah.
And I had even shown recently, if you see like Denise Richards,
Yes.
who she doesn't just look better when she's static. When she talks and moves, she has her old character back, where and everyone knows her face from back in the day, so you can actually look at her and say, oh my God, that's her character. She hasn't changed.
It really surprised me that she waited so long. And I'm really glad she did, because she ended up in your hands.
Yeah.
But coming from a place where she was one of the biggest actresses in the world, she was a Bond girl. She was known to be the most beautiful. And
Gorgeous.
then, yes, she's stunning. And then, to wait so long in this town specifically for a facelift. Talk to me about that process with her.
Well, so she had come to me through Robert Cohen, my partner, and we have a lot of common friends. So she had heard about me a lot throughout the years, and I've done a ton of her friends.
Sure.
She finally decided, she wanted to do it, and was at a nice time where things were kind of relaxed in her life, and decided to. It became very tumultuous right after with the divorce, but before was a great time for her. And she had a false reputation for having done too much work.
Yeah.
Being on The Housewives, everyone thought she had too much work done, but realistically, the only thing that happened was she had filler maybe 1 or 2 times.
Yes.
And they just placed it poorly. A very small amount, but a little bit can do a lot of strangeness on a thin little cute face.
Of course.
And that exaggerated with TV makeup, it makes it much more substantial and worse. So at that point, we decided to do the Auralyft with fat grafting, the type of brow lift that I do that's not a brow lift, upper eyelids, and this completely restored her character, lightened her, made her look younger, happier, everything. And when you look at her smile before and after, it's less cheeky, even though I added volume. And that's the thing that most surgeons can't comprehend.
With fat?
I added volume to her face with fat, but when she smiles, she looks tighter and less cheeky.
Yeah.
So how does that happen? This is from the muscle modulation. So she's one of the people, I do it on everybody, but I tightened the muscle tension, meaning the muscles can function better now. Nobody does this. It's sort of like working with musculature in the body. It's no different. And now she smiles better. She smiles more easily. It's more relaxed, less pull, less need for Botox. So I can actually modulate all these things. And even her brow lift, which is not a brow lift, when you look at her hairs on her eyebrow, they look more organized. So when you age, you get deflation in this area, and the brow hairs actually go into a disarray. So as opposed to, if you look at a normal eyebrow, the hairs go up and then start going lateral. When you have volume loss, they actually go up, lateral, down, and they move in different directions.
It's very obvious with men, because men don't
Yes.
keep their eyebrows manicured. So when you're looking at an aging face in a man, you do see that disarray with the eyebrows, absolutely.
Yeah, and part of getting it back is the volumization. So I do micro fat grafting here that, again, I don't think anyone does. So I have to learn it on my own. Gradually, it takes a long time when you don't want to mess anyone up. You can't just jump. So gradually, I improved, and even in hers, if you see, I'll show you. You guys can't see right now, but I'll show you that when you see it really up close, and you look at the brow. Let me show you here. Sorry on it. Well, so if you look here, do you see the brows look kind of disorganized and messy?
Yes.
The hairs. Now look how clean they look.
Oh my
And she's not manicuring them.
Wow.
This is just, they look cleaner because of that volumization.
Oh my gosh, that's such an amazing result.
And then this is the screenshots of videos. So this is video screenshots, and you can see how everything comes back. And then when
I want to see the smiling one. Yes, yes.
you see more cheeky, less cheeky, but that's more volume.
I do want to go through the vectors, because you gave a talk at the Cupid Compendium in November. You had an amazing meeting.
Thanks.
I loved being there. It was great. But I think your talk was my favorite. It was so interesting about a brow lift not really being a brow lift.
And it's not. So this is a problem that in plastic surgery has, again, perpetuated and propagated, is that the foundation of understanding is completely wrong. And surgeons, young surgeons, have a lot of trouble letting this go, because they look up to these older surgeons who haven't let it go and can't believe that something so perpetuated, so pervasive within literature could be wrong. And it is completely wrong. They just think that the guy coming and saying it must be wrong.
Okay.
But when I explain it, it will make total sense, and it always makes total sense because it's reality. So the foundation of brow lifting comes from literature that explains that we're looking just at the brow and trying to recreate curvature, recreate arc, recreate all this stuff that most surgeons, when you say this, they say, yes, of course, it makes so much sense to them. But it's completely false. The way they got this information of how to create the arc, how to create, is they studied a bunch of supermodels, legitimately. They took supermodels, studied them, and said, this is what a beautiful face is. And this is how you make someone beautiful and younger, is by giving them this exact design. So you design a brow and you somehow put it on their head. And this doesn't make any sense. It's not Mr. Potato Head. And it also doesn't reflect at all what happened with aging. Aging is a process. It comes from somewhere and it goes somewhere. So what you're trying to do is figure out where it came from and reverse it on that specific person. What they're doing is ignoring the person. And they go and take a supermodel and say, if I want to make this person look younger, I have to take this piece of a supermodel, which is one part of a big part, and I'm going to put it on their head. And that's the foundation of brow lifting. It is that. It is nothing other than that. Anybody who says different doesn't know anything. It is that. That is the foundation of all brow lifting. And when your foundation is incorrect, your treatments, your procedures to treat it will be incorrect. Because you're not really treating what the person had wrong with them. Instead, you're introducing something new. You're creating variety in this person, which didn't exist before. So they come up with ideas on how to do this, that, da-da-da. And the consequence of this is bad results and fear in the community, right? Everyone's scared of brow lifts because they want to look like brow lifted, but that's a bad brow lift. And it's not even a brow lift. They're scared of fat grafting because they don't want to look fat grafted, because these things have a reputation for being done so badly.
Yes.
Yet surgeons can't understand that that's the reality of it. It's done so badly, it has a bad reputation, not because we were all right, it's because we were all wrong. That makes more sense than we were all right, but they won't let it go.
So you were seeing results from brow lifts that weren't really brow lifts, and the results were poor. So how did you come up with this conclusion?
Aging face is easier than people think. You look for the laxity within the SMAS layer. The SMAS layer is, it's a system actually, it's not a layer, but there's one part of it that's called layer 3. So that's the middle part, and this was actually popularized by Australians. So this is Mendelssohn, and then Leonard Manelli, who learned under him, has been publishing about it recently. But the layer 3 is the superficial layer of the superficial musculoponeurotic system. And that's what creates mimetics that you can see on the outside, versus the deeper layer is what creates like your dimples, right? And the pulls on the mouth. That's a deeper layer. And you have other layers as well. But the layer 3 is what glides down and moves with gravity. When you lay down and when you sit up, this is what creates drooping and ptosis. So you're trying to treat this. And I learned that you can just feel for it. You don't need to look for it. And I started to feel for it in the face, and there's your vector. Simple as that. I started to feel for it over here, and I say, there's your vector. You can feel where it came from. Then I started analyzing, trying to understand, well, where's the skin going? Why does it look so exaggerated? And the reason we have difficulty understanding this is because we can't think in 3 dimensions. When you think in 1 or 2 dimensions, you don't get the whole picture. And if you look at the face, what makes more sense to you? That you had massive, massive movements with age and grew tons of skin and it went down in 2 dimensions, or you had compound small changes in 3 dimensions, which you multiply 2 times 2 times 2 versus just 2 plus 2. So which one makes more sense? That we had massive movement, massive changes, massive growth, and we have to do massive pulling to fix it, or that we had compound 3-dimensional changes, a 3rd dimension, and that 3rd dimension with the other 2 dimensions is what creates these big changes. And if you correct it in 3 dimensions, just as little, you also get big changes. So which one would actually make more sense? It's the second one. Exactly. And I show people this with the improved skin quality that you get in my photos without removing much skin, and the massive changes that you get with just a little bit of volumization because of finding the correct vectoring. And the correct vectoring requires the correct analysis, and that's the 3rd dimension. And we are 3-dimensional, so it's not shocking that there's a 3rd dimension, but photos are 2-dimensional. Movements that you feel are probably 2-dimensional. This is a 3-dimensional movement. It goes from a small front of head to a big back of head. And when you look at brow lifting, the ridiculous part about it is they're analyzing this, a line of hair, as though it's not connected to this, this, and this. This is all one piece. It moves together, but you're only looking at 2 little indicator spots. This is why they do brow lifting wrong. They're focused on 2 little indicator spots where it's the whole scalp that came down. So this is really a scalp movement. That's what a brow lift is that people think about, or why these changes are happening and what we have to fix is restoring the brow position by restoring the scalp position. The brow is just one indicator in a whole sea of things that we're trying to fix, but they focus on the one thing. Now, within the brow, yes, you have to restore it, but brow restoration is not lifting, it's volumetric. And that's where I showed you the disarray. That's with the fat grafting or microfat grafting. And then in some situations, you have to actually change the shape of the brow because the person never had a good brow shape. That is actual brow lifting. But surgeons don't realize that's the real brow lift, is if the patient had naturally a nasty looking brow, it was dipped off on the side, you can do something called a direct brow lift, which you make an incision here and you advance it. Change the shape. That's on those specific people, which is a low percentage of the population.
When did you start doing the fat grafting on the brow?
This is probably the past 4 years, and then incrementally getting more and more comfortable with it, where I'm able to add more without causing a problem. If you ever over fat graft somebody, it's almost impossible to fix. And you don't want to do something you can't fix. It integrates into the fat around it, and you can't just go remove what you placed. You can't just go liposuction it. You'll be taking the good fat, not the grafted fat. So fat grafting should never be overdone. However, the way it's taught is completely incorrect, and this is why people have fear of it. So the question surgeons always ask is the wrong question. Everybody asks the wrong question. It's a good question for me because I can answer it. The question is, how much of your fat is going to survive, so how much do you inject? That's assuming that there's, on every single person, you're going to have the same amount of fat survival and fat resorption. The question assumes that. That's a bad question.
Not true.
It's obviously not true. You can't predict if it's going to be 100% or 20% or 50%. So the question is wrong. So you have to explain to them, your thinking is wrong. You have to assume that you don't know how much is going to survive. And what you want to do is assume all of it's going to survive. Because if all of it survives and you're successful, fantastic. If you lose some, you didn't hurt the patient.
But if you put too much,
exactly.
you
If you assume 60% is going to survive incorrectly, but 80% survives, now you're screwed permanently. And you never want to permanently screw somebody. So, but again, the foundation, the basis of this is wrong. Their idea of statistics is wrong. They don't understand math. So they think that because 60% survived in a population, when you studied a population, that means that this person that you're going to operate on has a 60% survival, and then you add 40% to make it 100. That's not even good math in any way that you look at it. Not good for statistics. You don't understand averages, don't understand ranges, and then you don't understand percentages. You don't add 40% to 60 to make 100. That's not how percentages work. But this is what the surgeons do. And this is why patients are scared of fat grafting. Because that's how it's taught. That's the basis, largely in the whole world.
Well, to add more just in case.
Exactly. Exactly how much? 40%. That's the understanding, and that's why fat grafting makes everyone scared. And they use the wrong fat cell size. They take fat cell from your ass and your abdomen that's this big, and they put it in your face, where you have fat cells that vary from this big to that big.
So how do you make them minute?
The way I aspirate it is through a micro cannula, and it correlates to the smallest size of the fat that you'd find in the face. So if you look in the face, you'll have layered fat, where the top is tiny, the bottom gets bigger in general. I do the tiniest. So I don't care if I put it above or below, you're never going to cause a problem with that. What
lesson do you find yourself repeating over and over with the younger surgeons that come and want your tuition?
It's a complex lesson, but it's the general assumption that if your results aren't universally perfect or almost perfect, it means that your theory or your hypothesis is wrong. They can't grasp that because they think that common sense is correct. They think that the common understanding is correct. The common understanding in the world, in anything you look at, is usually incorrect unless it's perfect, right? Our common understanding of breathing is correct. We know we need to breathe, everyone does it, everyone survives. That is a proper hypothesis, assumption, and that's how you look at it. But if you look at the way politics go, and in most countries, and the way we run California, for example, everything goes wrong, which means that the way we run it is wrong. And when people come into office, they say, well, this is how it's always been done. And so that's how we do it. That doesn't mean it's right. In surgery, it's the same. They say, well, this is how it's always been done, which means that's how it's done.
And that's how they were taught.
Correct.
Yes.
That's how they were taught, but they assume that it's science and that it's correct and proven and evidence-based, which is absolutely not. Evidence-based medicine exists for real medicine, not so much for plastic surgery. Plastic surgery, as much as we are doctors, we're physicians, we're caretakers, we don't abide by those rules. We say we do, evidence-based, but when you look at the research for most of the stuff we have is really just storytelling. But really, it's hard to give evidence in this world. The real only evidence-based that we have is the anatomy, and most surgeons abandon the anatomy or make up new anatomy. So now it's like, what are you going to do with that information, right? So they abandon classic anatomy, which is true anatomy, and then they make up new anatomy. They start making, this is ChatGPT-able. They have something that they call osteocutaneous ligaments, okay? This doesn't exist in the human body. Anatomists, radiologists, real surgeons, general surgeons will disagree with plastic surgeons and facial plastic surgeons who use this terminology because they say it doesn't exist in the human body. Yet, in this surgical echo chamber, what do we have? People that have propagated or perpetuated the idea that a ligament between your skin and your bone exists. Why? Because they had an illusion. They thought they saw something. And they described it as a bone-skin connection, which doesn't exist. So they have this thing that doesn't exist. Then when they operate, they say you have to release this thing that doesn't exist. Then when they don't get consistent results, they don't know what to make of it. They don't understand it's because they didn't know the anatomy. So plastic surgeons have this ability, this amazing ability to abandon reality. They abandon science, they abandon anatomy, which is the basis of all we do, right? This is facial rejuvenation. Understand it, understand anatomy, understand where it came from, put it back to where it was.
Absolutely.
So our basis is not these research articles, our basis should be anatomy. But they not only abandon it, they change it and they add to it.
But they've also learnt from someone that's told them to do it a certain way.
Yes.
And there's so many things to consider. You're in an operating room, you've got the patient safety. So they're repeating something they've done so many times because they were taught by someone else.
Yeah, and that's how ultimately you manage your risks and all that is repeating something over and over again where you can minimize the damage you do to anybody, which is how you should practice.
But that doesn't necessarily mean you'll get good results.
Correct, or reproducible results. And the problem with this, the reason it's not cut off right away is because a broken clock is right twice a day. Okay, so let's say you have a terrible hypothesis, you're still going to get good results 2 out of 10 times. And what do those surgeons do? They take those 2 out of 10 and then they publish it. And then they talk about it in conferences and they say, look, this is my technique, this is what I did, look at my beautiful result. And they show you the result that proves their point, which was when the clock was right. So they wait till 2 o'clock, look, it's 2 o'clock, it's 2 o'clock. That's how it goes.
But their other results might be quite...
Their other results usually are not that good.
Yes.
Correct. Or not reproducible. Maximum 50%. When you have a correct hypothesis or a correct understanding of something and a correct ability to fix it, you're correct about 95% of the time plus. There's a 5% variability because of healing, the nature of healing. You can't control it. So there's always going to be a variability in how things heal. But if you're about 95%, meaning a 5% or less revision rate on something, and you look at the quality of the 95% and it's exemplary, that means that you have the right idea. You could have a 5% revision rate and have horrible results the rest of the time that you're just not fixing. That's different. And this is where you don't come and show your good 2 results, you show every result. So when I give lectures now and I show facelift results, I tell people, I'm like, listen, I'm not showing off. I'm not trying to show you I'm God, I'm grandiose, I'm better. I'm trying to show you the right way to do it. And if you don't want to do it, I'm glad if you all suck. It's better for my business. I'll go buy another car.
100%.
I'm not a business guy, but great. If you guys all suck, it's great. So I say, but I'm trying to show you something. I want to enlighten people because I don't like being in the dark and I don't want them to be in the dark. And I say, look at these results. This is 100 in a row. Judge them. Look at them closely. 100, and I show them 100 in a row. Not with me cherry picking. There's 100 in a row. Look through them and look to see what's more consistent. My theory and the way I do things, and it may be just my ability, but I doubt it. I'm not that good.
Well, I mean...
Well, I have some ability, but it can't be that to get 100 in a row, right? No matter how good you are. You have to have the correct idea.
Sure.
I go, or look at those guys who just showed you 2-3 pictures over 10 years.
Yeah,
so
a big difference.
Yeah, but, so some surgeons, again, can't let go, but it's not my job to force people to be better.
I loved what you said before because we are in the golden era of facelifts and we're also, I feel, in the golden era of skin. I think skin is big, skincare is big, but also facelifts. For a patient, not perhaps being able to come to Beverly Hills, what sort of research would you be doing or advising that patient be doing if they wanted to have a facelift?
Well, the general, let's say you're blinded and you don't know how to find somebody, what people have been doing recently is just looking for someone who does deep plane facelifting. But deep plane itself doesn't guarantee you're going to have a good facelift. It's a more logical approach because if someone's using it appropriately or optimizing that whole smash plane that drooped. But most surgeons don't really understand the deep plane and the nomenclature is all over the place. And people like me have contributed to the confusion. I've published articles where I describe things incorrectly too.
Right.
So when you just look for a deep plane, it doesn't give you the answer. But that's what people blindly do if they don't have anybody else. Otherwise, what you do is you really just research, you Google, you do whatever you can. Word of mouth is not always the best, but it is something that you can sort of rely on because you have something that you've seen in a couple people at least. And then you look through photos. Looking through photos is the most important, where you can go through profiles and see as many in a row and seeing how comfortable you feel with all of them. You're looking for consistency. You're not looking for the one that made it. This isn't like a recipe where you're trying to find the one recipe that you're going to want to eat.
And you make that incredible cake that one
Exactly,
time.
that one
take
time.
the photo and yes.
Yeah, you're not looking for that. You're looking to hire the chef to work for you forever, basically.
Yes.
And they have to be good at all times. So this is really what you're looking for, is consistency in the photo. And it's hard for me to explain that to patients, because they'll come to me and say, listen, I want this photo. I don't like that one. I don't like that one. I say, if you don't like what I do, don't come to me, because I'm going to do the same thing I did on all three of them, and you might get that one. And that's how surgeons do work, and people don't understand that. So you look for consistency as much as you can, and then you really go from there. Meet the person and get a feel for it. You know, see if they're a nice, beautiful, understanding, caring person, or if they're cold-hearted like me, or whatever they are.
Yeah,
but
hardly.
But see what they are, because you'll come across a sociopath and you'll feel it.
I meet all different demographics in my non-surgical practice, but I met a lady who works in the kitchen of a hospital, and she said she never liked her jawline and decided to go to Turkey and have a facelift, and she paid $5,000. And I have to say, her jawline looked great.
Yeah.
However, when I moved her hair to clean her face before she was having injectables, the scarring was
Tremendous.
absolutely terrible.
Yeah. Unfortunately, not every person has access to the best surgeons.
No.
But price point is not as big of a difference. There's plenty of like amazing surgeons who are super affordable, and it is variable based on city and country. But they're out there. You just have to look for it. And in facelifting specifically, you do want to look at the scars.
Yes.
It is very important, because it's an indicator of what happened in the surgery. So it's a telltale sign. There is also a fallacy within surgery that's taught that putting tension on deeper layers gets rid of tension on superficial layers. And this is what's taught to where smassplication came into popularity from just skin only lifting, is that they would put tension in the smass layer and then remove it from the skin layer. That was the idea. But this is a fallacy. It's not true. Tension in any layer in the face is tension. It's not going to go away. It just translates in a delayed fashion. So it doesn't come out on the surface until 6 months versus if you hadn't done that, you would have seen it at 1 month. So that's the only difference, really. So when you look at the scars, and the ear is contorted and it's twisted and it's lengthened, it looks long and fat. And it's stretched, and you don't see the tragus, and you see all these things, you know that that facelift was done under duress. It was done under tension, and you're not going to have had a big or durable result for most of it, or there's pull lines and stretch lines, because it was pulled and stretched.
There's definitely stretch lines.
And in facelifting, you don't want to pull and stretch. You want to release and reposition, and that's it.
I loved being at Cooper Compendium. It was such a great meeting, and you have this knack of bringing all of these different specialties together. One of my favorite talks, besides your talk on the not so brow lift, was the lady who does the tattooing for men after facelift surgeries for the scarring. What was it like doing the Cooper Compendium and bringing all those people together?
Well, it's great. The whole purpose of this compendium, we've had other ones where I did peri-oral and we do different things. This was to teach people how to see.
Yeah.
And this is the problem where people say, like, where do you think you got ahead in life? Where do you think you got ahead compared to other surgeons? And the realistic, biggest kind of benefit that I had, or advantage, was that I have insight. And it's just, I'm able to see things and understand things. I sit there and I watch. And it's not that hard to do. I just have patience. And I sit there and I watch, and I like watching things, and I like understanding things. When you're doing surgical procedures, filler, Botox, all this kind of stuff, when you're at these conferences, what excites people is not the ability to see, it's not the knowledge of the anatomy, it's not understanding, it's simply toys and doing the next procedure. How can I learn more procedures? Because they think learning more procedures makes them better. That's what they think. This is what they've been taught. So they're on this never-ending search for a new procedure, a new technique, the coolest new technique, this lip technique, Russian lip technique, fencing, all this stuff. They think that those things are what makes them better, is the technique. Has nothing to do with it. What makes you really, really good is an understanding of the anatomy. And when you really understand it, and you understand aging in the face and how it moves, you can manipulate it reproducibly. I don't want to teach people new techniques and just say, learn this new technique. I want to teach them how to see. And that was the idea of this whole thing, is when you look at someone's face, stop thinking about how you can manipulate it. Okay, stop. Like, I'm begging people, just stop doing that. That's what they do. They sit there and they think they're an artist if they can look at you and I can do this to you. It's ridiculous. Sit there and try to understand the face. Look at it, see if you can x-ray and tell me what's going on from the surface to the bone in every single layer just by looking at it. I can draw it on your face. I can show you exactly every muscle movement, every bit of what's happening, where the fat loss is. I can show you all that. So the purpose of this was to give them the insight. That's why we started with teeth. We went from teeth to bone to skeleton, and then out to the skin, muscle movement, fat modulation, and then the little touch-up stuff, which was like, what do you actually do with facelifts, and who do you want in your pocket? Who do you want to know? You want to know the dentist, the orthodontist, the orthognathic, you want to know the dermatologist, and you want to know those two people that I had, which was Dana Elise for the hair removal.
Yes.
And then for the tattooing was Ruth Suissa.
She's amazing.
So these are people you want to have in your pocket. So that was the purpose of this conference, to give you the tools to see and then who to know.
Yes.
And once you're there, that's a better foundation than you go to a conference and they taught you 20 bullshit techniques that are all new, that have no bearing on reality, and it really advances you nowhere in life versus building your foundation. You go back, build your foundation, you're better. And this was a foundational conference. Everything was about foundation. And half the people got it and they said, wow, this was like, I can understand now. I see it now. I get it. Now when I'm doing a lip lift, now when I'm doing cheeks, I'm going to look at the teeth first and I look outwards. The other half are like, yeah, you know, I wish you had more techniques.
Oh, really?
I
was the opposite. I loved it. I learned so much. It was so great.
Because you have insight.
Yeah. Well, it's also, I've been in business for 15 years. I've been injecting for 20 years. You know, I started with 3 vials of Botox and I was cold calling my mother's friends. Would you like to come and try Botox? Like this was, you know, it was, you know, I had $80 days sometimes. So I just did some frontalis injections and I'd have to go home with my tail between my legs. Like this doesn't just happen.
Right.
You know, so how was it for you when you were starting the business?
It did just happen for me because I was...
of course it did.
I moved very quickly.
Yeah, okay.
And I don't have delays.
But you were ready.
Yes. Well, that's why. So I don't allow delays in my life because I don't like inefficiency.
Yeah, okay.
And I can't sit around twiddling thumbs.
No.
So before I moved back, while I was in my second fellowship, I was already jump-started.
You were ready.
And I was ready to go. I had my website. I started promoting myself even though I didn't know how to.
But how were you promoting yourself?
At that time, social media was getting, 2013.
Yeah.
So social media was getting started. I was using Facebook, Instagram, Google AdWords were already a thing at that time. And then doing little ads here and there where I would just try to get people in and I would pretty much do free stuff.
Yeah.
Just because I wanted to show them that I was good. And I didn't care about money. I still don't care about money. I'll still do free stuff all the time. I'm like, I don't tell people that, but I do it all the time just because I'll meet somebody and they can't afford surgery. And I'm just like, well, I like you. I'll just do it. Like, really? I'm like, yeah, come. So back then I was like that too. And I would just keep going. And the more people you touch, the faster you grow, the better you get, the more popular you get. It's just like, it's a high school popularity contest partially. And so I was doing a lot of Botox and fillers. I was doing 20 to 40 people a day, 6 days a week. And that's a lot of people to touch. And that's what got me going very quickly. And I had trained so heavily that when I got to that point where it was just me, I didn't have any delays in that either. Because I was trained so heavily beforehand in New York. So when I came back, because I wasn't just doing residency and 2 fellowships, I also was doing after hours. I worked twice as much as everybody else.
What were you doing after hours?
I would go work nighttime at Columbia. Daytime, I'd be in Steve Perlman's office doing plastic surgery.
Right.
Then on weekends, they'd have a facial fracture. I would go do that with plastic surgeons.
Okay.
Then they'd have an orbital fracture. I'd go do that with the oculo guys. Then the birthmark case would be going on a Sunday. I'd go do the birthmark case. So I would do that on days when other people were sleeping, and then I'd go out and party afterwards. And I just keep going. So I'm very efficient with my time. But that's why when I got back, I didn't have that delay.
Okay.
But really what set me apart in my understanding of things was being exposed to things that other surgeons weren't. So they were all looking in the same direction, doing the same thing all the time. And you're not exposed to anything new. This is all repetition, slow evolution. I exposed myself to oculoplastics, plastics, orthognathic, dental. I saw the whole face. I saw everything. I understand the face. Now I can manipulate it. And this is what's been happening. Why my techniques work so well is because I'm not listening to what everybody else has been telling me. I figured out my own understanding. And the understanding that I have is no different than 70 years ago understanding of anatomy. The confabulation that's happened is from 1995 forward when people started creating new ligaments and structures that don't exist and confuses people.
So what's exciting you right now?
Well, it's this muscle modulation, this mass optimization, which again, so if you mention that to a surgeon, they're like, what the fuck are you talking about? It's not a field that exists. So it's my own field, but I can show you patient after patient after patient where I can modulate their muscle function. And I can get them, it looks like they need less Botox, like those little peau d'orange in the chin. I showed it in the conference.
Yes.
So how soft it looks with no Botox.
So soft.
And it looks like there's no volume in the face. And it looks more symmetric.
Yes.
And symmetry really doesn't have much to do with beauty except for midline structures. So symmetry is not beauty. But when you fix the face and you fix it maximally on both sides, it tends to look more symmetric, softer, which just means you have less of a disparity from one side to the other. You want it to flow naturally from one side to the other. It doesn't have to match. But I've been able to get more symmetry without trying on all these patients. And my revision rate's going lower, my success rate going higher. So that's the most fun for me. And that's what I've been playing with every single day.
Do you think that's how you started getting better, was your revisions?
It's the painful way.
Yeah, it's very painful.
So, and this, I think we mentioned it last time, like I don't have a fear of failure at all because I don't really care. It doesn't bother me. I have a fear of repeating failure and being a loser. So if you don't try and you don't change, you're a loser. If you keep failing in the same thing, you're a loser. But if you tried, you failed, and then next time you made it, you're a winner. And then that for me is fun. That's the game. You keep going. So the revisions, they bother me when they happen because I have to do them, but then you learn from it and you never do it again. That's the key. Never do it again.
Never do it again.
Exactly. So you learn and you kind of move on from there. And this is a struggle I had in like an English class in college where I got into an argument with the professor. I wrote my first paper in a way he didn't like. It was about Spaceballs, and I compared it, showing the Holocaust analogies, and he said it has nothing to do with the Holocaust. I'm like, oh, I think it does. It's and alien movies and everything. There's a lot. There's a lot in there.
Yeah.
Spaceballs is a very smart
movie.
movie.
One of my favorite movies.
Yeah, very intelligent movie. And he didn't like the way I wrote it. So I said, you know what? Forget me being intellectual. Let me pander this guy. I'm just gonna go and write how he wants me to write, which has nothing to do with learning or anything. But he's a moron. And I'm like, I can't deal with a moron. I can't win against the moron. No. He's not logical. So I got A's on the rest of the papers. He still gave me a B in the class.
Really?
Yes. And so I had to go fight it. And I went to the dean and everything. And I explained to the dean, I said, listen, I got a B on the first one. I got A's on the rest. This guy's somehow averaging it. His math is bad. He still gave me a BB plus. It doesn't make any sense. Let's just say it did make sense. I had a B on the first, A on the rest. That means I learned exactly what he wanted me to learn, doesn't it? And I did it in the best way possible, right? I go, that's an A, isn't it? He goes, well, I don't want to get involved. So in general, I'm that way, where I come in, I start with a B, and I'll get A's on everything else.
Because you figure it out.
Exactly.
Yeah.
If I got a B the whole time. But either way, I struggle with people repeating things over and over and over again.
Yeah, makes sense. I've been fascinated with a thing called Looksmaxxing. There's a streamer called Clavicular who encourages young men to smash their bones with hammers to create a more defined look. And it's very interesting, but it really does open up a whole area that males want to look better too. So talk to me about the male facelift, because in my experience of seeing work over the years, men have thicker skin, so often the results aren't as good. What do you think?
Well, smashing your face I think is hilarious. So anybody who does it's evolution, right?
Yes.
Darwin, smash your face. It's fine. The Chinese did have a slapping technique also, so you can't blame clavicular fully, where they would slap themselves to plump up their skin, and it's similar like what microneedling does in like a very basic way. But facelifting in males, I love to do. I do a lot of it. I do more than most people do. I think percentage-wise, it's still a small percentage of your practice, maybe 10-15%, even if you do a ton, just because women do more surgery, but more and more men are looking to do stuff, and there is a Wall Street Journal article that they published with my work in it showing.
Yeah, I shared that article. That was fantastic.
That guys are coming, and it's great because it makes people comfortable with doing it. That's good and bad, because if they're too comfortable, they might go to a bad surgeon. Now, if a man is getting a facelift, a male facelift is less disguisable when things go wrong. That's the way to think about it. So it's not different than a female facelift. It's just when things go wrong, you can't hide it with hair. And classically, things always go wrong, and in women, they always hide it with hair. Just like you said with that woman, you pull back. So they hide it with hair, guys can't. So when you see that a shit facelift was done on a woman, they kind of hide it with makeup, whatever, they look a little fake. On a guy, can't hide it, looks terrible. That's the only difference. Realistically, if a man is doing a facelift or a woman, you're doing the identical surgery, or you should be, because the anatomy is identical internally, with the exception of just some density of the tissue. But your release, your repositioning, your lift should be identical. And the same goes with the eyes, the same goes with everything else. Unfortunately, the way we're taught, most of the procedures are wrong and they come out. So Bradley Cooper, for example,
Yes.
is one where recently he was in the news for his eyes looking strange, and the same kind of criticisms that they went after with Renee Zellweger before.
Definitely. Bradley Cooper is an example of a celebrity male that got a lot of attention for perhaps having some plastic surgery recently. Talk to me about his result.
So Bradley Cooper, what we're assuming happened, we don't know. He had some weight loss, most likely too. Everyone's on GLPs at this point, so you can assume possibly that has something to do with it. But it looks like he had the same issue happen to him that happened to Renee Zellweger when she lost her character with upper eyelid surgery. Now, what surgeons are taught in general is that an eyelid looks older. Your solution for this is cutting away skin. That's the assumption that the only thing that happened to your eye is skin grew. It's an incorrect assumption. Anybody would see that, right? But that's the assumption and that's how they treat it. So the treatment has been incorrect forever, and this is why people are scared of eyelid surgeries, because it changes the character of your eye. Because they're just cutting away skin when the problem wasn't just skin. Realistically, when you're looking at, I show you like Denise Richards' eyes, her eyes are her eyes from before. When I've done my favorite actors in the world, their eyes are their eyes from before. I'm not scared to tamper with it because I can reverse it and change it back to what it was. So it started here, it went to here, I took it back to here. What's happening in plastic surgery is it started here, it went to here, but then they take you to here. So they introduce a new variable again, taking you to a different place, which changes your character. If you don't want to change character, you have to do a reversal, especially with the eyes. So for him, it looked like his lid crease was a little too high. It looks like he has had fat loss in there, which could be from the surgery, it could be from the GLP, could be from either, but it wasn't treated.
And it looked quite hollow.
Yes, and that's what it looked like to me as well. Now, he may not have had surgery, but if we're assuming he had, that's what would have happened, and that is what happened with Renee Zellweger. They just cut away skin. They didn't revolumize. And this is a problem that you see in restoring character around the eyes is this area deflates. It's not just growing skin. The reason skin looks excessive on the face is because the contours change three-dimensionally. So back to the 3 dimensions, it's a compound change. And when you move things in all 3 dimensions with collapse, drooping, you get massive changes in skin quality appearance where it looks like you have a lot of skin excess. And I put up that picture at the conference of that older lady, and I said, what do you guys see here? Everyone is thinking lots of extra skin, lots of extra skin. And I go, but look at the after photo. I barely removed any skin and I fixed everything. So was it really a lot of extra skin? And they can't wrap their minds around it. They're like, maybe it wasn't. They can't get it. So extra skin is rarely the problem. We're not growing that much skin, right? Things would be just falling off our face. It doesn't make sense. But the treatment plans are all based upon removing skin because extra skin is the problem, and it's not. So 3-dimensional restoration is really how you restore how someone looked, their character, where they were, and then if there's a little extra skin because the head is smaller when you get older, trim that little extra skin to accommodate for it. And that's what we're doing, right? When you're a baby, your head on the inside skeleton is this big, the skin's that big. Then it all grows to the max when you're like 20 something. And then this stays the same because the skin already grew, but the bone and the fat and everything starts to recede under it. And you have to accommodate at some point for the smaller underlying soft tissue and bony skeleton. So that's why you remove skin in surgery, not because skin grew extra, right? But people don't get that.
No.
They think skin just keeps growing somehow, like it's an expansion effect.
So getting back to men, talk to me about your facelift, because you do such exceptional work with males.
Thanks. Well, it's exactly the same as I do on women. It's no different. We wrote an article. So Dominic Bray in London was publishing an article on nuances of male facelifting. And I made him change it because I do a lot of male facelifts. He does a lot of male facelifts. I said, Dominic, don't you see what we're doing? I go, there is no nuance to it. It looks nuanced because we're doing the identical thing properly. It looks like we customize it for everybody because we restore everybody to where they were. Everyone thinks that's customization. It's really applying your knowledge base of reversal. And that's all we're doing in the same procedure, same anatomy, little difference in anatomy between one person to another, but not a man to a woman. And so we rewrote the article and we published it saying, surgery will look nuanced when you understand it and do it better, period. There is no difference between a male facelift and a female facelift. And for guys getting facelifts, you better find somebody who does both extremely natural with no scarring, never have hair pulled in front of the ear in a photo. It's always pulled back. And then you can see really if you're going to get that reproducible result. Because on a guy, you're so screwed. You can't hide it once you do it. Even a woman, you shouldn't be doing it, but at least you can hide it with some hair.
I really think there's going to have to be a part 3 because I've got all of these questions that I haven't even got to yet. But thank you, Dr. Ben Talei, for joining me on The Face.
It's my pleasure. The face is the best place to be.
Exactly. Thank you.